Hello, everybody, and thank you for joining us for another one of our amazing specialist educational seminars. And today we have the very lovely Dr. Graham Neilsen, who is talking to us about sexual health. He has over 30 years' experience in the field, working both globally with the United Nations, but as well as with other organisations and in various countries where there are epidemics of sexual health conditions. He has been pivotal in the establishment of the Gender Health Service, and as a senior staff specialist, he's co-chair of the Queensland Sexual Health Clinic Network and a member of the Sexual Health Ministerial Advisory Committee. So this guy is at the absolute cutting edge of sexual health and sexual medicine, which is a fascinating area and emerging, and I believe something that we will be seeing much more of in the medico-legal space moving forwards. So if you can all keep yourself on mute while he's speaking, but at the end of the presentation, there will be the opportunity for you to ask questions if you have any, or if you have to go before it's finished, you can always type your question in the chat and I'll make sure that it gets read out and answered. You'll get the recording probably within a day, I would say. And of course, it will be stored on our YouTube channel with the rest of our other amazing seminars. So without further ado, thank you so much, Dr. Neilsen. Over to you.
Well, thank you very much, and Michelle and Leroy, and good afternoon to everybody who's online and those who view my presentation later. I'm not going to be using any slides. I think it's a lot easier and more human, really, just to have a chat about what I've done over the years and how I might be useful for you in your work. So, as Michelle mentioned, I have several decades of experience now in working in sexual health medicine. I'm also a public health physician, so I have actually got two specialties, sexual health medicine and public health medicine. And a lot of the work that Michelle just described was really looking at the public health aspects of sexual health in terms of preventing HIV transmission in developing countries. So I spent 18 years overseas doing that. Prior to that, I was a senior specialist already in Australia, working in New South Wales at that time. And then since I've come back, I've been back in Brisbane 10 years, working both in private practice and in public practice with the Sexual Health and HIV Service in Brisbane. As Michelle mentioned, I was the driving force behind the establishment of the gender service at Royal Brisbane and Women's Hospital. That's now been going 6 years. We started in 2017. And in private practice, most of my work is with trans and gender diverse people, a fascinating and rapidly expanding area of work and need, and something I thoroughly enjoy doing. I think it would be useful really in terms of my usefulness to you as potential clients, I think I'd like to highlight a number of aspects of my career where they're more likely, the aspects might be of more interest to you. So I previously spoke with one of the MAG staff people about a high profile event which involved pretty serious medico-legal consequences. And this one is now something like, I think it's almost 30 years old, but it was a really important experience for me, and it was also an object lesson in the public health implications of poor risk management for HIV transmission by surgeons. And the case in question, some of you may well remember this because it got a lot of media at the time. It involved a surgeon in Sydney who was conducting minor procedures in his private rooms, and 5 consecutive patients in one session became infected with HIV. And of course, that raised a whole range of questions about whether or not this was indeed transmission from him or from patient to patient. I was the first person to interview the first of the 5 people involved, and this was a young woman living in Canberra at the time, in fact, I wasn't a specialist. I was a registrar at Sydney Sexual Health Centre, and I flew to Canberra to interview Case A, as she was known in the way the public health investigation broadened out. So the critical question here from New South Wales point of view was whether or not this person was credible. Was there another mode of transmission that might actually obviate the need to do any further investigation, or was this person otherwise not at risk of HIV, in which case the New South Wales would have to pay a lot more attention to the situation. And to cut a long story short, I went and interviewed her. I spent several hours interviewing her, by the end of which I was very confident that her story was completely true. I had no doubts really about the truth of what she was sharing with me. And the implication of that was that New South Wales had to conduct a much more thorough investigation, following up with the other 4 patients who were infected. I was also the first person to interview the surgeon, and subsequently other officials from New South Wales Health were involved in doing very thorough investigation of both his premises, his supplies, and also his ordering practices for consumables, to try and match up whether he his ordering of, for example, local anaesthetic vials matched his caseload. And that was where the investigation subsequently concluded, on the basis of a mismatch between what he should have been using in terms of anaesthetic vials and his caseload. And so the conclusion was that he had been most likely, and there's still medico-legal reasons about implications of what I say here. The conclusion was that it was most likely that his practices of reusing anaesthetic vials resulted in one patient's blood residue in the vial being transferred to each subsequent patient, and thereby infecting each of them with HIV. So a pretty horrendous story. It was subsequently published in the journal The Lancet. It was of great interest in terms of both clinical implications as well as public health implications. And I am very proud of the role that I played in that investigation. Obviously, I had to write up quite a bit of documentation at the time to ensure that New South Wales Health was on solid grounds in pursuing the surgeon in question. So a pretty major event and experience in my professional career, and one which I think stood me in good stead for future medico-legal and policy work in both the sexual health and HIV context. So I guess the other things I'd like to share, I believe we're doing questions at the end rather than interrupting what I'm having to say. So the other areas that I'd like to highlight are that it's broader than my experience, I guess, in terms of medico-legal work. Certainly in my clinical work, I've been called upon numerous times to provide reports to lawyers and insurance companies for patients for whom I've been caring. And that's pretty much bread and butter for me as a specialist to do that sort of work. But I've also engaged in other more tangential ways. So, for example, I've had to draft letters for lawyers involved in immigration cases. So HIV positive people applying for permanent residency or citizenship in Australia, and the immigration department requires a pretty thorough report for people in that situation. So I've done many of those in my work with the Sexual Health and HIV Service in Brisbane, and also in other contexts, including my private practice. I have also done other work which involves quite high-level negotiation and writing of documentation. So in some of the work that Michelle just mentioned, working with international development agencies overseas. So I worked for a number of international non-government organizations, and in the last couple of years before I left Bangkok, I was also engaged with different United Nations agencies, for example, the World Health Organization, the United Nations Development Program, the United Nations Population Fund, UNFPA, and also some other agencies, non-UN agencies such as the Asian Development Bank, Bill and Melinda Gates Foundation, and so on. So all of that work was pretty much high level. It was usually either looking at policy development, national guidelines, sometimes regional guidelines, training documents for health practitioners, often with a public health agenda in terms of reducing stigma and discrimination. And I did similar work in Southern Africa before I came to Bangkok in 2020. Sorry, in 2023 years ago. So in a lot of that work, apart from the writing tasks that I've just described, I was also involved in developing funding applications for various agencies, and they were for various donor agencies such as USAID, the United States government, the Australian government, again, Bill and Melinda Gates Foundation, and the World Bank, and others. Those were very high-profile submissions, typically involving millions of dollars. And for example, I wrote a submission for funding from the United States government for our programming in Bangladesh for $25 million, and we were successful in receiving that funding. I've also been involved in research grant applications. I've just been involved in an NH and MRC grant application with the University of Southern Queensland. I'm about to start work as an associate professor with the Public Health School of Public Health with the Faculty of Medicine at the University of Queensland. And in that capacity, I'll be, hopefully, if we receive funding, we'll be working on some research looking at models of care for trans and gender diverse people in custody, so trans prisoners in both Queensland and New South Wales. So that's quite a broad snapshot of some of the work that I've done over the last couple of decades. Michelle mentioned that I was also working as the co-chair of the Queensland Health Sexual Health Clinical Network, and also the Ministerial Advisory Committee on Sexual Health for Queensland Health. I ceased doing those recently. I actually left Queensland Health in September, just so that everyone's clear about where I am now. I'm no longer involved with Queensland Health, and that may be of use in terms of assuaging any questions you might have about conflicts of interest if we have medico-legal issues that involve Queensland Health. I'm no longer an employee of Queensland Health and working exclusively in private practice. So those two positions are now in the past behind me. That's, let me just see, I've made a few notes just to see what other things I should highlight. We were talking earlier, and I'm sure some of you will have questions, but Michelle and I were talking about my work in the gender area. Trans healthcare is becoming a massive area of work, and it carries with it considerable medico-legal implications, both for clinicians, but also for families. We've had, for those of you who've been following this area of work legally, we've had major flip-flopping in the last couple of years in terms of the requirements for parental consent for children under the age of 18. And we've had cause to celebrate and then cause to despair And again, in Queensland, but nowhere else. We've also recently had cause to celebrate one more time, but only for Queensland. There are going to be, I'm sure, increasing numbers of legal disputes, particularly for minors, where parents are in conflict, for example, and consent is problematic. These situations can often arise in the context of custody battles for the care of children and so on. I might just leave it there if that's okay. I'm sure, having said all of what I've just said, that must generate a number of questions. So I'd like to hand it over for questions and leave it open. Thank you.
All right. Does anyone have a question that they would like to ask of Dr. Neilsen? While you're thinking of those questions, I have 3 questions from people who have been unable to attend today.
Okay.
So the first is, are you seeing a trend, and you did address before the parents in conflict issue, and I'm presuming that you're talking about children who are transgender and maybe seeking to transition or maybe seeking to access puberty blockers. Is that sort of the area that you're thinking about?
It's both puberty blockers and what they call cross-sex hormones. So very young adolescents around the time of puberty are often very keen to stop the progress of puberty because it clashes with their gender identity. So for a simple example would be a transmasculine adolescent who is dreading the development of breasts. They are keen to present as masculine at school and in the community at large. And should they commence breast development, then it becomes much, much more challenging for them to transition socially at school. And of course, depending on the school at which they're attending, they may be attending a single-sex school, in which case breast development is fine, except for the fact that they want to be identified as masculine. If they were attending a co-ed school, the development of breasts will often elicit a lot of trauma on the basis that the development of their breasts will draw a lot of attention to them that they would rather not have and make them feel doubly traumatized around their gender incongruence.
Right.
So that's the simple context,
That's
I guess,
the context. Yep.
for puberty blockers. But as they mature, so if they're post-pubertal, they will also be keen to commence masculinization or feminization using hormones to do that. And under the age of 18, in all states of Australia, with the exception of Queensland currently, that requires assigned consent from both parents. That is remarkable, if I may say so, in that in the real world, it's often very, very challenging, if not impossible, to get the signed consent from both parents. One of the parents may be uncontactable. There may be a dispute over custody. There may be a history of domestic violence or even child sexual abuse, in which case the last thing you want to do is to engage with a hostile parent and prevent the process from proceeding. So a very vexed area from a legal point of view, but it's also a source of great trauma for the children involved.
Absolutely.
And the parents, obviously.
Well, the question that this person puts then comes at the flip side of that, which is when all of these things have commenced and have occurred, and then the young person determines that perhaps they didn't actually want to be the other gender, and now they've had a mastectomy and other feminizing or masculizing procedures done, and they want to go back, and they're looking at various medical negligence actions against psychiatrists, sexual health professionals, plastic and reconstructive surgeons.
Okay, I'll try and be brief on that. I have a lot to say about that issue. The first thing I'd really like to emphasize is that people in that situation are extremely rare. There has been a lot of media and quite hateful what I call propaganda, trying to popularize the idea that young people are being severely harmed by being provided gender-affirming treatment and also gender-affirming surgery. And in fact, gender-affirming surgery itself is quite rare for minors. So young people under the age of 18 rarely get top surgery, as you mentioned. That's a very unusual thing in the first place. The people who are looking after young people in this setting do work in multidisciplinary teams and give very, very considered processing and assessment of those young people before any decisions are made in terms of providing either puberty blockers, cross-sex hormones, or a surgical option. When I talk about propaganda, there have been a couple of very noteworthy and really, I think, shameful journalistic efforts on this topic recently, probably the worst of which was a program by the Spotlight, an episode of Spotlight on Channel 7, where they really highlighted a small group, I think it was about 5 trans people who had changed their mind. And I think for the most part, it almost goes without saying that young people who do that are probably already in a pretty poor space in terms of their mental health. And so part of the reason they're conflicted about starting and or stopping their treatment is to do with a high level of background depression, anxiety, and simply trauma. A lot of young people in that situation have been highly traumatized, both by their gender incongruence, but also other sources of trauma, such as child abuse, bullying at school, and so on. So those young people are often very traumatized. And even so, in my experience, the proportion of people who change their minds, both as young people, but also as adults, is less than 1%. There is a widely quoted paper, which is a really shoddy piece of research, quoting a detransition or desisting rate of some 22%. And we have reviewed that paper extensively in recent times, and it is scientifically extremely poor and frankly should never have been published. That's how bad it was. But it's being used a lot by people with a transphobic agenda, often in the style of American politics, to use as a source of fear for parents to get terribly upset and tormented about whether people like me are harming their children. It's basically, it's highly political. It's most often, it does have a political agenda rather than a child protection agenda, but it's often dressed up as a child protection agenda.
It's multi-layered, isn't it?
Yeah, so it's a really vexed issue, and it's very troubling in terms of the discordance between what's true, what actually really happens, and then what people with that political agenda are presenting publicly. But yes, you're right. There will be inevitably legal trouble ahead.
All right. Now, and the next question is out of that topic a little bit, and that is for people who have a sexually transmitted disease that they have to live with. So whether that is HIV, AIDS, whether it is something like herpes virus or something, in terms of complications that these people might have with their health, their mental health, or their physical health in some way down the track as the result of harboring those infections in their bodies, are those illnesses things that are likely to result in other comorbidities or other medical presentations later in life? So in other words, could somebody claim that they got something from work, a mental health condition, a vascular condition or something, but in actual fact, it's the result of the infection that they already carry?
Okay, that's a very interesting question. I thought you were going to ask me about the medico-legal issues involved in transmission of sexually transmitted infections, including HIV.
That's coming next.
It's never far away. So, that's a really interesting question. So in terms of HIV, first of all, HIV infection these days is really unlikely to cause any significant comorbidity for the simple reason that we have highly effective, safe treatments available. However, there are also a decreasing number of people who will have the old-fashioned manifestations of untreated HIV infection, where HIV disease is allowed to progress and lead to either opportunistic infections, and many of those can produce comorbidities such as meningitis, encephalitis with mental health and neurological deficits, and just general morbidity in terms of weight loss, fatigue, losing people's ability to go to work. So, pretty profound disability in a more general sense due to HIV disease. There are some specific non-infectious manifestations, particularly neurological effects of HIV, where HIV directly harms the brain. And so people can develop presenile dementia and lose their ability to function long before, for example, the age of 50, and it's due to the HIV neurological disease. That is a major disability. Fortunately, it's also become pretty rare these days.
Mm-hmm.
Treatments, when they're used, are very powerful in terms of preventing both the direct and the indirect consequences of HIV infection.
Mm-hmm.
But I think I should qualify what I'm saying around, so who might this apply to in the future? And so while we're talking primarily there about people who are long-term Australian residents or citizens and have acquired their infection locally, being diagnosed, hopefully fairly early in their HIV infection before they develop manifestations of HIV disease, that's great in terms of the very low likelihood that those people will develop those comorbidities that you're talking about. There is another increasing cohort of people who acquired their infection overseas. So I'm talking there about people who've immigrated to Australia. Certainly we see quite a number of people seeking permanent residence on the basis that they're political refugees. So asylum seekers, for example, who are also infected with HIV. And in that situation, those people often present with late-stage HIV disease, with all of the things that we used to see, 30 odd years ago, when we used the now largely inappropriate anachronism in terms of AIDS rather than HIV disease. So a lot of those people coming to Australia may well present with an AIDS-defining illness, and that's a very different kettle of fish.
Right.
Very low CD4 counts, severe immune deficiency, and much more challenging from a clinical management point of view. So that's a second group and an evolving cohort of people of whom we'll see much more in Australia from here on. Okay.
Next question is about syphilis, which I hear is on the rise again. And it carries with it its own unique long-term effects, correct?
If syphilis is untreated, absolutely. Syphilis, in many ways, untreated syphilis shares a lot of parallels with HIV disease, in that syphilis, like HIV, the organism that causes syphilis can infect pretty much every organ of the body and produce disease in all those tissues. So it can affect the brain, the spinal cord, it can affect the liver, it can be transmitted from mother to baby and cause congenital syphilis, which often results in stillbirth, or severe disease for that child, which can be quite difficult to manage if the mother has not been treated during pregnancy or prior. So it's multiple manifestations of syphilis clinically, many of which are actually quite extreme. The good news there is that syphilis, while it can be a very serious infection, it's actually has been curable for a very, very long time. And it continues to be curable with penicillin, which we've been using for many, many decades. Ever since penicillin came on board in the 1940s, we've been able to cure syphilis. And remarkably, syphilis has not evolved resistance to penicillin. So we are still able to cure syphilis. Certainly early syphilis we can cure with a single injection of penicillin.
Wow. Goodness, I better not get it then, because I'm anaphylactic allergic to penicillin.
Okay, there are alternatives.
I'm not planning on getting it.
Well, for people who are not pregnant, we can use the very cheap, commonly used antibiotic doxycycline, and also erythromycin, which is not an option, not a great option. But for pregnant women, of course, doxycycline is contraindicated, and quite a challenge there clinically. But the management of people who are penicillin allergic is challenging. It's depending on the situation. So someone who's pregnant, for example, may require desensitization to penicillin so that they can actually receive penicillin during pregnancy.
Okay.
But
another interesting point that was raised is in relation to your observations we're talking now almost 20 years of the human papillomavirus vaccination for school children getting that. And the question is is the evidence showing that that really is resulting in a dramatic reduction of cervical cancer and also of, I am told, esophageal cancer?
I'm not certain of the answer around oropharyngeal or not esophageal cancer. It's oropharyngeal cancer. So really in the throat is where HPV infection can cause squamous cell carcinoma. I would expect that the incidence of that has declined, but off the top of my head, I won't be saying that that's certain. But I will say that we are very confident and have seen a massive decline in the incidence of cervical cancer. And we also expect that we'll be seeing a massive decline in anogenital cancer for men as well. So HPV, really is a major cause of cancer for both women and for men. So penile cancer, anal cancer, HPV is really has for a long time now been cited as the cause of those cancers.
It's a huge one, isn't it?
It's a huge issue. And the great news is that, yes, with 20 or so years of HPV immunization through the school program and catch-up programs for adolescents and young adults, the evidence is really clear, most strongly shown for both cervical cancer, but also interestingly for anogenital warts. And while that might not be so frightening, anogenital warts certainly cause their own morbidity, both in terms of it being embarrassing, so a source of personal distress and anxiety, but also stigmatized for people in a sexual relationship or with prospective sexual partners. Often a lot of fear and anxiety that needs to be managed well to reduce that. And the great news is that condition has not quite disappeared, but it used to consume an enormous amount of our time clinically, and it's now very uncommon for us to be managing anogenital warts clinically. It's sort of a bygone disease, thankfully.
Wow. Well, look, that has actually been really very, very interesting. Anyone else have any questions? Usually when that happens, it's because we've answered them in what we've talked about. This is a fascinating topic, and to be honest, I could chat about it forever because I just find it really titillating. I mean, I told you I was wandering around singing Marvin Gaye's Sexual Healing all morning.
Yes, that's very sweet. But on a more serious note, I love my area of work, and I find it fascinating and frankly a source of privilege in the sense that medically I am privy to the stories of the most intimate aspects of people's lives, which, you know, we need to manage confidentially, of course. But for me as a clinician, I learn a lot more about what we humans get up to. I find that fascinating. I mean, it's remarkable what I learn in terms of not just sexual behavior, what people do sexually, but also the implications of sexual behavior, sexuality, gender identity, and so on, and how that affects people's lives and relationships. And so in that sense, it's a fascinating area to work, and I love it.
Fantastic. Well, thank you so much for your time and sharing with your expertise today. Hope you have a great rest of the day and a lovely weekend. And everyone else, thank you so much for joining us, and we look forward to seeing you at our next seminar.
Fantastic. Well, if there are no other questions, I'd like to thank you all for your attention and hope that I can help you in some way. Thanks very much.
Have a great day. I'm going to stop the recording now.
Thank you.